Welcome, my dear friends. Myself, Professor Dr. Rajendra Raghuveer Deshpande from Pune, Maharashtra State, India. As everybody knows now that Professor Deshpande is MD in Ayurvedic medicine, the subject Kaya Chikitsa, and MD Ayurvedic physiology, that is Kriya Charira. And I am a retired ex-professor in the CRC Pune. Anyways, this class is related with the Swasthavritta subject. But my dear friends, in each video, especially some videos, I am appealing to all my viewers. Don't go, because many people think, oh, it is for students. Oh, go. No, my dear friends. This topic is so important. It is useful for the medical students, maybe BMS, BHMS, MBBS, anywhere. Then these topics are very important for the professors, for the doctors, for the common man, and for the patients. So these videos are useful to each and everybody. Only you have to keep patient and have the eager to learn, because Dr. Deshpande is explaining in a very simple language but scientific information. No cheating. Okay. So we are discussing today two important diseases, that is malaria, and second will be leprosy. So I request, if you are the students, please note down this, open your notebook, 18th of February 2024, and two names you have to write down: malaria, M-A-L-A-R-I-A, this name is in front of you, and second is a leprosy. You will say, sir, why you are taking these two different diseases in one lecture? My dear friends, you first write down another name, because this is the part in Swasthavritta syllabus, paper 2. Please write down paper 2. Will you please write down paper 2, part A? Part A, please write down. And epidemiology, EPI, epidemiology. Under this epidemiology subject, you are learning these different diseases. We are having 7 or 8 important diseases. I will let you know the names again for epidemiology. You can be asked in the examination about leprosy, dengue, typhoid, measles, malaria, tuberculosis, cholera, etc. And I have already completed in the previous lectures tuberculosis complete, cholera complete, typhoid complete. And now we are studying malaria and leprosy, and only two will remain, that is dengue and the measles, that we may discuss in the next lecture. So this is the topic about epidemiology. Now my students again will ask me, sir, tell me again, repeat, sir, repeat once more. What is epidemiology? So epidemiological concept for you. In every lecture I am telling this. Epidemiology is a study of population, study of Maharashtra state, people in the Maharashtra state, study of Mumbai, study of Thane, study of Pune, study of Pune means the people living in the Pune city. Are you getting? So study of this population. Why? To determine the frequency and distribution of the diseases. Frequency and distribution of the disease. And second, why we are doing this? To measure the risk of these particular diseases. For example, I can study my Kapila Society, Kokhle Nagar, Pune area, to see how many malaria patients were there in the last year. How many people, male, how many female, how many age, 5 to 15, 15 to 20, etc., etc. Then how many have the sanitation around them well good? How many have the problem with the mosquitoes? How many fumigation has been done by corporation? So these all the things I have to collect the data. And for that data collection, this epidemiology branch is very important, which is taking care of transmission and control of the diseases in the population. This is the study of population, study of the people. Yes. Let us start with the malaria. The name itself. Mal. Please write down. Mal is a bad. Mal, M-A-L, mal means bad. Then area means air. When the air is not good, there are a lot of mosquitoes around you at night. Then one mosquito, then you can get this infection, that is malaria. So this is from the mosquito. Second simple thing I will tell you. How to diagnose? Malaria is a periodical. In Ayurveda, it is called as a Vishama Jwara. Shita Purva Jwara. Shita Purva Jwara. Shita means Jwara Purva. Before getting the pyrexia or the high temperature, the patient gets rigor. Don't write chill. Don't write chill. Rigor. R-I-G-O-R. Fever with rigor, important two causes. Fever with rigor, only two causes. Please write down. One is malaria and second is UTI. UTI, urinary tract infection. So you can ask whether the patient is having burning micturition, whether he is having cloudy urine. You can ask dysuria, hematuria. You can ask, then you can get info. If nothing urinary complaints, only fever with rigor, it may be malaria. Go for blood test. Blood test. You have to go to the laboratory, take the blood. The pathologist, the technician will take the blood, will prepare the smear, blood smear. That is called PBS. Please write down. PBS. Peripheral blood smear. Peripheral blood smear for MP. Write down. MP is not Madhya Pradesh. For malarial parasite. For malarial parasite. Okay. So we will start actually the disease. This is just background. This is protozoal disease. You can write down this word protozoal. Protozoa. And what is the organism? Plasmodium vivax. This is the species. Plasmodium vivax. Okay. This is very important for MCQ. ARAPGET. In all the lectures, I am telling what can be asked in the MCQ of entrance examination for MDMS, which is called as a ARA, All India Entrance Test for PG. Okay, ARAPGET, entrance test. Okay, Plasmodium vivax, this is the name of the organisms. Who is giving the transmission from one person to another? By female mosquito. Female Anopheles mosquito. Female Anopheles mosquito. Okay. Now, when we are saying the epidemiology, this word is very important. That is the problem statement. How is the problem? How is serious? Worldwide, nationwide. Today, 109 countries are considered, are prone, their possibility, endemic for malaria. Whole world, 109 countries. In India, malaria is a major public health problem. Infection due to Plasmodium falciparum is giving many complications. In India, which are the states? Chhattisgarh, dangerous. Madhya Pradesh, dangerous. Orissa, dangerous. Andhra Pradesh and Maharashtra state. About 50% falciparum, this mosquito causes, are seen in the tribal areas, not in the city, due to the limited health infrastructure and also lack of drugs. Medicines are not available. In peri-urban areas, that means around the urban areas, Pune city, Pimpri-Chinchwad is peri-urban. Malaria is influenced by poor sanitary condition. These are the causes. And low socio-economic group, poor people are there. They cannot take care of proper hygiene, proper cleanliness, proper sanitation. And the villages, they don't have the proper air, proper light. Drainage system is not good. Sewage system is not good. So these are the problems. Poor and sanitation is the problem. High malaria transmission belts are seen along the international border or the state border. So everywhere there is a checkup. Okay, we will go a little bit further. Now, these are the epidemiological factors. Let us see malaria. Let us see malaria epidemiological factors. Number one, agent. Who is transmitting? Who is doing this infection? Malaria is caused by 4 species. Again, MCQ for entrance. Falciparum vivax, Falciparum falciparum, Falciparum malarii, and Falciparum ovale. So you write down P vivax, P falciparum, P malarii, and P ovale. I will wait. Please write down these 4 species, very important. But maximum cases are vivax, Falciparum vivax. So vivax name is very important. And 30% are from falciparum. These are the in Marathi we say the jati, prajati, etc. types and subtypes of the mosquitoes, like the families. These are the families from the mosquito. Now, life history. Malaria parasite undergo 2 cycles of development. How it is developing? First is a human cycle, that is asexual cycle, and number 2, mosquito cycle, that is sexual cycle. So asexual in the human body and sexual in the mosquito body. What is asexual? It begins when an infected mosquito bites a person and injects sporozoites. Sporozoites. It's like a toxin. And they have the following phases. Number 1, liver, hepatic phase. These toxins or the small molecules, creatures, sporozoites, disappear within 1 hour from the blood. Many of them are destroyed by phagocytes, soldiers, phagocytes, but some reach the liver cell, and after development, they become hepatic schizoids. The names are little bit complicated, I know that. But you can remember the important hepatic, sporozoids, schizoids, which eventually break out, and a shower of merozoites. So these words I know, you can write down 1, 2, 3 like that. First sporozoites, then schizoids, then merozoites. I know, my dear students, these are difficult. That's why I am requesting, write down this time and say 10 times, 20 times. For example, sporozoites, sporozoites, sporozoites. Then schizoids. I know this is difficult. And merozoites. Okay. Now I am shifting my curtain to the right side to see the some part from this right side. Okay. So here is a She diagram, systematic diagram of the cycle, sexual cycle and asexual cycle. I will try to just move. Oh, sorry. Okay. Can you see here sexual cycle and asexual cycle? One by one, we try to see. For example, here hepatic schizoids, then merozoites. They enter the RBC, red blood cell. Then there is a tropozoites. Okay. Then again the gametocytes. Then here you can see they are moving, entering the stomach of the mosquito. Then microgamete and macrogamete. This is a sexual cycle. This is in the mosquito. Then zygote, ookinete, oocyte pass through the body cavity and reach the salivary gland of the mosquito. So after bite from the saliva of the mosquito, that all the toxins, they are moving like this. From the human being, they are getting the gametocyte, that means the final product which enters into the mosquito, and again the cycle goes on like this from one person to another. Okay. But I can understand this is little, I'm not saying 100%, but little difficult. So at least in the first round, you just remember it's going to the liver, then RBC, then what you can say, the gametocytes, and then entering into the mosquito. Some important steps you remember. Erythrocytic phase. Many of the merozoites are quickly destroyed, but a significant number of attack to RBC, red blood cell, and penetrate it and pass through the stages of tropozoites and schizoids. The erythrocyte, that is RBC's phase ends in the liberation of merozoites, which infect fresh red blood cells. Clinical attack of malaria occur at this stage. When they attack on the red blood cell and that poison is coming out, liberation of the merozoites, then you get fever with rigor. Actually, that's why it is said that whenever the blood sample has to be taken, it should be taken, during the rigor phase. When the afterward fever will go down. If you examine the blood when there is no fever, there is no rigor, you cannot get this particular shizon or this particular, you cannot detect that eggs of that mosquito. Then gametogeny. In all the subspecies of malaria, some erythrocytic forms do not divide but become male and female gametocyte, which are the sexual forms of the parasite which are infective to the mosquito. Remember this. Now, when these particular gametocytes, it's like a male gamete and female gamete in the human, but that is not human, that is for mosquito, eggs of the mosquito. These eggs of the mosquito will continue their sexual cycle in the mosquito body. So at least in this lecture, you must understood there are in the human body, there are some steps, and in the mosquito, there are some steps. In the human, that is asexual. But in the mosquito body, that is sexual cycle. In the human, there is a liver, there is RBC. This is enough. And here you can see gametocyte cycle. It begins when the gametocyte continue further development in the mosquito, in the stomach of mosquito. Now here, not liver, here stomach. The male and female forms escape from the RBC and are known as gametes. Like male and female gamete, eggs. By a process of chemotaxis coming together, microgametes are attracted towards the female gamete and cause the fertilization of the female gamete and form a body known as zygote. Same like the human. It penetrates the stomach wall of the mosquito and develops into an oocyte on the outer surface of the stomach. Oocyte grows and develops many sporozoites. Okay. I think sexual cycle you have understood. Now I have to go for the next page, that is on the second page. For every stage, I request you are giving me what you can say, some space, because it takes time to adjust the screen. So kindly excuse me for the same. Okay, I will try my level best to give you the best knowledge. Okay, we are talking about the sexual cycle in the mosquito. When the oocyte mature, it bursts and liberate the sporozoites into the body cavity of mosquito. Many sporozoites migrate to salivary gland here of the mosquito, not human being, of mosquito, and mosquito now become infective to the man. I know, my dear friends, I understand even the common man, don't get afraid. This is only how that mosquito eggs are growing and how they are becoming infective, because female is only infective. And how that female mosquito is taking the birth, that cycle has been explained. One is on the side of the human being, that is asexual cycle, and one in the mosquito bodies, that is sexual cycle. In the human body, something is occurring in the liver, something is taking place in the RBCs. Then here, they first acting on the stomach, then they are coming to the saliva. Okay, that much you must understand, and remaining factors you will remember slow and steadily. Don't worry, be happy. Now, simple thing. Now, these cycles are over. Now, we will talk general host factor. Okay, can you see? Host means the patient. Host means patient. Who is the host? Patient. Malaria affects to all ages. Anybody, children, youngsters, old people, newborn infants, very interesting, are resistant to infection with falciparum. Infants will not be affected. Lucky. Men are more commonly exposed due to the outdoor life they lead. But of course, I don't agree with this, because now females are also taking a lot of work outside and they are also moving outside. Persons whose RBCs are Duffy negative, a specific antigen, are resistant to falciparum vivax infection. Pregnancy danger. Pregnancy danger increase the risk of malaria. Malaria during the pregnancy can cause, very important. You write down the only keywords, pregnancy danger. What will happen if the pregnant lady gets the malaria? EIUD, intrauterine death of the fetus, baby will die. Or premature labor during the 7th month, during the 8th month, sometimes abortion. So the pregnant ladies should be protected well. Maybe mosquito net should be there, odomas, some cream, some perfumes, whatever you do. But pregnant ladies should protect from the malaria. Ill ventilated, proper ventilation is not there. Ill lighted houses provide the space for mosquitoes. If there is a darkness all the time, mosquito will come. Sleeping outdoors, refusing the spraying of houses, the corporation comes and spray anti-infectant. Replastering of the walls after spraying and not taking personal protection are all risk factors for malaria to occur. Epidemic of malaria is influenced by immune status of the population. This is the most important word. I think this is the important word not for malaria, for any disease. Ayurveda says person's immunity is the most important factor from cold to cancer. Ayurveda says whether the person will get malaria, whether the person will get leprosy, it depends on the immunity, fighting capacity of a person. And that is why Ayurveda advises dinacharya, daily regimen, rutucharya, seasonal regimen, food, dietetic rules, exercise, occupation, or prakriti, all the guidance is important. Okay. Now we will talk about environmental factors. We will talk about epidemiology of malaria. We are discussing epidemiology of malaria. So here, India's geographical position and climatic conditions very warm. Of course, that is very good. We have the good sunlight. No Europe and America has having the advantage like sunlight. But unfortunately, as this is a warm country, there is a more chances of transmission of malaria. Maximum prevalence is from month July to November. Okay, July, August, September, October, November. Rainy season is also favorable because lots of mud is there, unhygienic conditions are there, and dirt, dust is there, and mosquito will breed. When the relative humidity is high, mosquitoes are more active. Rain, just now I have, provides for the breeding of mosquitoes and given rise to epidemics. Write down, rainy condition, bad. Rainy, many mosquitoes. Rain, many mosquitoes. The heavy rain have adverse effect due to the flushing out of the breeding phases. Of course, that means they will cause another problem. But in general, rainy season, we have to be protected for ourselves. Very clean. Man-made malaria. Oh my God. So what is this? Man-made malaria. Burrow pits, garden pools, irrigation channels, and engineering projects led to the breeding of mosquitoes. Whenever there is a stagnation of the water, always eggs of the mosquito will start growing and more mosquitoes will come up. Okay. Now we will talk about the transmission of these mosquitoes. Can you see here? Transmission. Okay. Malaria is transmitted by the bite of the infected female, Anopheles. Write down this name, Anopheles mosquito. Or some can take the screenshot because Dr. Deshpande is going slow. Nothing to be worried about. Mosquito is not infective unless the sporozoites are present in its salivary glands. So this poison is very important. Sporozoites. sporozoites. Malaria may be transmitted accidentally by the hypodermic, intramuscular, or intravenous injection of the blood or the plasma. For example, blood transfusion or malaria in drug addicts. So, intravenous by giving the, that's why whenever we donate the blood, there is a checking for malaria, there is a checking for hepatitis B, and even in the blood donation camp, their history is more important. The person will come, take my blood, take my blood. No, no. They will ask you whether you have any disease, like whether you had the malaria in last 1 month, 2 months, etc. Whether you are suffering from hepatitis B, whether HIV patient is that. All these precautions are taken, and then the blood is taken. Okay. So, a person who had malaria should not be accepted as a blood donor until, remember, 3 years afterwards. So, even in the last 3 years you have the malaria, please, please don't donate your blood. Don't donate your blood. Be honest, because of your this mistake, another person will suffer, another lady will suffer. So take care. Don't donate blood if you have the malaria. Minimum 3 years, don't donate blood. Clinical features of malaria, these are most important topic. So we have to shift. 3 stages are there. I will move my curtain on the right side, and then we will discuss. Okay, we are discussing malaria. We are discussing epidemiology of the malaria, and now we are talking about the clinical stages. Very important topic. Even if we don't cover the leprosy, don't worry. We will continue the next time. But cold stage, hot stage, and sweating stage. Please write down malaria symptoms. Malaria symptoms, there are 3 stages. Please write down. These are the symptoms. Can you see? Cold stage, hot stage, and sweating stage. What is cold stage? Fever with rigor. Starts with the lassitude, headache, nausea, chilly sensation, chilly not rigor, followed by rigor within a period of an hour. The temperature rises up to 39 to 49 degrees centigrade. Headache becomes severe, also accompanied by vomiting. Pulse is rapid and weak. Tachycardia normally is 80 per minute, so it may be 100. This stage lasts for about 1 hour. Parasite can be demonstrated in the blood sample. That's why I am repeatedly telling you, ideal blood sample should be taken in this stage. Then you can find out the malarial parasite in the PBS. Hot stage. Patient feels burning, hot, and throws out his clothes and blankets and all these things. Skin becomes hot and dry to touch. Here, can you see here? Nausea disappears, but headache will continue. Pulse is full of boom, boom, boom. Respiratory rate will increase, and this stage lasts for 2 to 6 hours. So 1 hour, this 2 to 6 hours, and then sweating will start. Fever comes down with profuse sweating. Skin becomes cool and moist, and this stage will last for 2 to 4 hours. But this attack of malaria will come every day at specific time. Doctor, every at 2 p.m. in the afternoon, at 2 o'clock, this my child is getting first rigor, high temperature, and it comes down at around 4 or 5 o'clock. Every day at 2 p.m., this child is getting fever. So when the frequency and the repeated cycle is there, every day 2 times, every day at particular time, and the same stages, cold stage, hot stage, sweating stage, this is 100% you are dealing with the malaria patient. Okay. Now, so specific cycle is more important. Every day or every after 2 days, some people will get every alternate day he is getting the problem. Okay. So febrile attacks. See, can you see here? with definite intermittent periodicity. This word is most important word for malaria. Periodicity is important, depending upon the species of parasite. Falciparum shows classical 48 hour. Every after 2 days, this fever cycle will come. The mortality is more than other forms of malaria. Falciparum is a serious disease. Vivax shows the same features but milder form and more regularly divided into hot and cold stage. Falciparum malaria shows cycle of 72 hours every after 3 days instead of 48 hours. You can make a chart for falciparum, for example, every after 2 days. Then what next is Vivax every day, like that. You can make a chart. The complications of malaria are anemia. Definitely, the red blood cells, hemoglobin will come down. And when RBCs are broken down more, what is the graveyard for RBC? Where they are buried? Yes, that is spleen. So splenomegaly will be there. Spleen size will enlarge. Spleen is on the left side of your body. Remember, liver is on the right side of your body. Spleen is on the left side of the body, below the costal cartilage, below the ribs. There is also pancreas. There is also a spleen. Normally, in any human being, any person, liver and spleen are not palpable. Liver and spleen are not palpable physiologically. So when you can feel that, it is called as a splenomegaly or hepatomegaly. Here we are talking about splenomegaly. Sometimes that parasites can attack on the brain, very dangerous. Cerebral malaria and acute renal failure. Kidney will stop functioning. Okay. Now the diagnosis that depends upon the demonstration of parasite in the PBS. Write down this word, peripheral blood smear. Thick film is more reliable. Latest sample and rapid diagnostic tech is a dipstick assay for detection of falciparum, falciparum, this particular species. Okay. Now we are talking about malaria epidemiology, and here you can see the measurement of malaria, how the statistics is done. Annual parasitic incidence, annual whole year API is equal to confirmed cases during 1 year divided by population under surveillance. That means who are diagnosed. For example, in my Gokhale Nagar community, I have found that 20 cases was of malaria, 100% diagnostic, and the population is nearly about, you can say, 5,000. So 20 divided by 5,000 and multiplied by 1,000. So this can be done accordingly. Malaria control. The nation, India has decided, Bharat has decided, National Drug Policy on Malaria in 2007 is giving the importance, emphasis on complete treatment in diagnosed cases of malaria rather than one single dose presumptive treatment of suspected case of malaria to avoid the chloroquine resistance in falciparum, Plasmodium falciparum. Okay. So this chloroquine, you write down this name. This is the most important medicine for the malaria. Chloroquine, most important. First line of treatment of malaria is chloroquine. Please write down. Chloroquine is the most important. Uncomplicated malaria, chloroquine gives in adults. How much is the dose? 600 milligram on the day 1 and day 2 and 300 milligram on day 3. For falciparum, again write down the dose. Chloroquine, first day 600 milligram, second day 600 milligram, but third day reduce 300 milligram. Now we will see Plasmodium vivax cases, how they should be treated. So my dear friends, please allow me to move on the curtain to the left side of the computer, and then it will be more easier for you to understand what Dr. Deshpande is talking about. Okay. I think I should go down. Yes. here. Thank you for your nice patience. So, Vivax, Plasmodium vivax treated with chloroquine in the dose of 25 milligram per kg body weight over 3 days. Okay. Now, severe and complicated malaria cases should be hospitalized. Better way. As I have already told you that there may be cerebral malaria and can be treated with injection quinine 10 milligram per kg body weight IV drip. It is not given directly through the IV drip. 5% dextrosaline to be run slowly. One bottle over 4 hours. 4 hours you have to give very, very slowly that injection. Tablet mefloquine. Very important name. Can you write down? Mefloquine. I will wait. Mefloquine. You have to write down. Mefloquine is to be used only on the patient who are resistant to chloroquine. So those who are not responding well, fever is not coming down, then in spite of chloroquine, you can start mefloquine. Primaquine should not be given to the pregnant woman. This is very important. Primaquine should not be given to the pregnancy, infants, and glucose 6-phosphatase deficient person. This you can decide by the history or by blood checking. This is the enzyme. Glucose 6-phosphatase deficient person should not be given primaquine. Chloroquine, some side effects are definitely there. The most important is the gastritis. It can cause the nausea, vomiting, blurring of vision, sometimes headache. But of course, we have to accept because we want to treat the malaria. So at least you can take after food and some antacids can be given. But these are not so serious that you should stop the chloroquine. The chloroquine must be taken. Okay. Now, treatment in the high risk areas. What type of treatment that is suggested by the government? So, treatment in the high risk areas. Presumptive treatment, that means prevention is better than cure. All suspected or clinical malaria is 1 tablet of chloroquine 10 milligram per kg body weight, that is 600 milligram comes for the adult dose. Then also you have to add tablet primaquine 0.75 milligram per kg body weight, approximately 45 milligram for adult dose. This is day 1. Now day 2, chloroquine 10 milligram per kg body weight. Day 3, third day, again chloroquine 5 milligram per kg body weight, approximately 300 milligram. This is C600, 50% reduced, 300 milligram adult dose. Now, radical treatment after microscopic confirmation of the spam. When you check the blood and it is confirmed that yes, this is malaria, these are suspected. Now this is confirmed. Tablet primaquine 0.25 milligram per kg body weight, 15 milligram is adult dose daily for 5 days. In falciparum, Plasmodium falciparum, no further treatment is required after if you have taken these above treatment. Okay. Now, prevention is better than cure. We are talking about epidemiology of the malaria. Okay. So, in low risk cases, presumptive treatment, day 1, tablet chloroquine 10 milligram per kg body weight, same like above, 600 milligram is adult dose. Radical treatment after confirmation. Plasmodium vivax tablet chloroquine 10 mg per kg body weight, single dose. And tablet primaquine 0.25 milligram per kg body weight daily for 5 days. Falciparum is more serious. Mortality rate is high. People can die with the falciparum, but not with the vivax. So here chloroquine 10 mg per kg body weight plus tablet primaquine 0.75. Can you see here? Here is 0.25, here is 0.75 milligram per kg body weight as a single dose. Now, chromoprophylaxis. This is recommended for the travelers from non-endemic areas and a short-term measure is expected. Now, I will have to go on the right side. So just few seconds only. Few seconds. We are discussing what we are discussing? Epidemiology of malaria, where we have seen the asexual and sexual cycles. Asexual is in the human being, and sexual cycles is in the mosquito. So we are talking about the chloroquine dose for the soldiers, police, and labor forces surviving in the highly endemic areas where they are working, where there is already malaria is existing. So for these people, soldiers, police, and laborers, we have to give the prevention, drug regimens. Chloroquine, can you see here? The name of the chloroquine, this is a generic name, but this is the market brand name, the name given by the company. Can you see here? Risochin. Risochin for prophylaxis. Adult dose is 2 tablets of 150 once in a week. Only once in a week, because this is prevention. Then Proguanil. Proguanil. 200 milligram, 2 tablet once in a day. Proguanil. Dr. Deshpande is going slow because you are expected to write. Mefloquine, different names. Mefloquine, 1 tablet of 25 milligram once in a week. Once in a week. This is once in a week. This is once in a day. Then doxycycline, 1 capsule of 100 milligram once in a day. Okay. So this is the prevention. Now we will see what to do with the mosquitoes. That is called as a vector control strategy. Please write down title. Vector control strategy. How we can prevent the mosquito breeding, mosquito attack, how we can do that? Spraying, this corporation is doing, indoor surface of the houses with residual insecticide like DDT is still effective measure to kill the adult mosquito. DDT spray. Nowadays, due to the resistance to the DDT, new insecticides, like for example, malathion. Write down this name, malathion, or phenitrophion. Phenitrophion are used. Then you can use the mosquito repellent. Then, for example, odomas, protective clothing, full shirts, not half sleeves, bed nets, mosquito coil, good night coil. Give the individual protection or the family protection. Anti-larval measures. Eggs should not grow. Some modern larvicides like Tamifos give long effect with low toxicity and are used widely. So you write down this name, Tamifos. Classical method of malaria control is to reduce mosquito breeding sites. Reduce the mosquito breeding sites. For example, drainage or filtering, deepening or flushing, management of water level, and intermittent irrigation. So this is called as a vector control strategies. We are talking about epidemiology of the malaria. Now I think we are at the end. So here you can see global policy regarding malaria. Global policy regarding malaria. Objectives of the anti-malarial treatment are rapid cure of the infection, reduce the morbidity, that is dependency, and mortality, that is the death, prevent the malaria-related anemia and other serious complications. Unfortunately, anti-malarial vaccine not available, my dear friends. So I think in today's lecture, I will not start the new topic of what we were talking about because of the less time with us, unnecessary fast I do not like, because I wanted to talk about some leprosy part also, but an incomplete two parts I do not like. So in this lecture, we will only conclude this malaria, but we will revise some other topics. Okay, we will revise. Don't worry. Be happy. I'm going to tell you something audio information as a part of revision. So nothing to be worried about. But leprosy we will continue in the next lecture of Swasthavritta, that is, of course, the next Sunday. Yes. What is the revision, sir? What is the revision? Revision is always taking place first with the syllabus, second with the question papers. So here I am going to repeat Swasthavritta, paper 2. What are the important topics in the syllabus? Paper 2 is having part A and part B. This whole paper 2 is a Samajika Swasthavritta, social preventive and social medicine. Because in the paper 1, individual, Dinacharya, individual. Here all things are for the public. So paper 2 is for public, paper 1 is for individual in Swasthavritta. Okay. So part A, Jana Padodhans, then Vayu or the air. I am just repeating the topics. Then Jala or the water. Then Bhumi and Nivasasthan. Fourth topic, Bhumi. Bhumi means land. And Nivasasthan, housing. How should be the housing? Fifth is a Prakash or lighting. Sixth topic is Dhvani Pradushana, that is noise pollution. Seventh, Vikirana, that is radiation. 8, Apadravya Nirmulana, that is disposal of the solid waste. 9th, Mala Nishkasana Vyavastha, excreta disposal. 10th, Shava Vinash, disposal of the dead body. 11th, Rutu Evam Vatavarana Jnanam, that is meteorology. We are talking Swasthavritta subject syllabus topics. 12th, disaster management. 13th, occupational health. 14th, school health services. 15th, that we are studying right now, epidemiology. 16th, non-communicable diseases, epidemiology. 17th, Chikitsalaya Bhavana or hospital building. All the 17th topics I mentioned from Swasthavritta paper 2 part A. Swasthavritta, social preventive medicine. I am talking part B, that is Prathamik Swasthya Sanrakshana. Prathamik Swasthya Sanrakshana. Second, Parivar Kalyan Yojana. Parivar Kalyan Yojana, like family planning. Third, Matru Shishu Kalyan Yojana, mother and child welfare program. Matru Shishu Parivar, Kalyan Yojana. Fourth topic, preventive geriatric, old people, geriatric, old people. Fifth, WHO, World Health Organization. Sixth, international health agencies. Seventh, Alma Ata Declaration. Very important topic, Alma Ata Declaration. 8, National Health Policy 2002. National Health Policy 2002. 10th, Swasthya Prashasana Administration. Swasthya Prashasana. 11th, National Health Programs, that I think we have seen something. 12th, National Nutritional Programs. Now, still we have some minutes in our hand. So I would like to tell you something about Alma Ata. So can you concentrate? Alma Ata. If you don't mind, please write down the name Alma Ata. Alma Ata Declaration. ALMA. Alma Ata. ATA Declaration. Very common question for the oral and for the written. Why this name? Why this is Alma Ata? To discuss the different things about healthcare, Jagtik International Conference was held in Alma Ata in very previous 1978. Please write down 1978. Alma Ata International Conference 1978. Okay, and different governments of 134, write down the number, 134 countries and many NGO, non-governmental agencies are joined to this conference. Okay. Now, this Alma Ata conference, the declaration, what are the what can say the proposals or the decisions were taken at Alma Ata? They have decided to work jointly, working together for 8 following elements, 8 things in the health concern. Number 1, Alma Ata Declaration. We have, they say, conference is saying number first point, education about prevailing health problem and methods of prevention and controlling them. This should be done. It is decided in Alma Ata that education is most important of the public. Second, promotion of the food supply and proper nutrition. So there should be enough food for everybody, even for the poor. So this is second point. Food is more important. Third point, adequate supply of the safe water and sanitation. Adequate supply of the water, good water and sanitation. This was the third point. Fourth point, more important to the mother and child, maternal and child health care, which also includes family planning. Only 2 child, family planning. Fifth point, Alma Ata Declaration. Alma Ata Declaration. Don't forget this word, because we may not get the time. So you have to write down all these things. What is the declaration? Fifth point, immunization. Immunization against infectious diseases. Sixth point, prevention and control of endemic diseases. Prevention and control of endemic diseases. Seventh, Alma Ata Declaration. Appropriate treatment of common diseases and also injuries, accidents. Eighth point, provision for essential drugs. Provision for essential drugs. Okay. So I think you must aware that Alma Ata Declaration is basically giving the emphasis on individual and community participation, individual and community partition in all these activities. Okay, my dear friends, I think this is enough time for today's lecture. We have discussed in very detail about malaria, and we have also discussed, I can say, Alma Ata Declaration. So you write down all these points, and we will see you in the afternoon with the Charak Uttarardha lecture talking about Jwara further. Thank you very much. Take care and see you in the next video. All the best.